My job today is really just to set the stage, because we're going to have more discussion about GLP-1s, and here are my disclosures again. So we'll start with a question, which is, what is the principal mechanism of action of GLP-1 agonists in NASH? Suppression of hepatic lipogenic genes, increased hepatocyte fatty acid oxidation, increased adiponectin production in the liver, decreased delivery of fatty acids and glucose to the liver, and reduced intestinal permeability. Can we have the audience poll, please? It's a pre-test to see who knows what. Audience poll, please. Kya hua? All right, well, moving on. You lost your opportunity, okay? You all know what you know, and then we don't want to get any further behind. So GLP-1 is an incretin. It is released from L cells in the intestine, and essentially GLP-1 and glucagon are almost alike, and they have a common precursor. And through alternate splicing, you either make glucagon or you make GLP-1. In the intestinal L cells, you release GLP-1. GLP-1 sensitizes the islets and allows it to release insulin, so it is therefore called an incretin. Now, GLP-1s have many biological effects, and they have principally a central effect where they affect the satiety center and reduce appetite. In addition to that, now it turns out GLP-1s have a myriad non-CNS effects as well. From the cardiovascular perspective, it has some cardioprotective effects. From a vascular perspective, it has been shown to reduce strokes. From a renal perspective, it reduces the slope of decline of GFR in people who have metabolic syndrome. In addition to that, from a gut perspective, it reduces postprandial lipidemia. From a pancreas perspective, as I mentioned, it's an incretin, releases insulin release. And so many of these, actually, from a fatty liver disease perspective, also are potentially beneficial. Now, very important, GLP-1 receptors are not present in the liver. So all of the effects of GLP-1 are mediated through its effects outside of the liver. But through all this reduction in adiposity and systemic inflammation and improving the overall metabolic health, it reduces inflammation. The delivery, because it improves insulin sensitivity, it reduces fatty acid and glucose delivery to the liver, so there's less substrate to form fat. And so it improves glucose metabolism, and it also essentially results in improved glycogen stores. So there are a number of GLP-1 agonists that have been developed. And semaglutide right now, as you talk about pure GLP-1 agonists, is the one from a NASH perspective, is the one with the most data, although all of them have same class effects. And these are the original data with semaglutide with 0.05 all the way to 0.4 milligrams, showing you can get 10 to 15% weight loss. And with the current dosing of 2.4 milligrams weekly, you can get up to 20% weight loss with semaglutide within 6 to 12 months. Now, of course, the weight comes off, but if you stop the drug, the weight comes back on. So we still haven't solved that problem of needing therapy long-term once you start therapy, unless you work on the behavioral underpinning and allow people to change their lifestyle enough while you're pharmacologically bringing their weight down. Now, the reason GLP-1 agonists have taken the metabolic field by storm is summarized in this slide. If you look at all-cause mortality, composite renal outcome, worsening of renal function, or hospitalization for heart failure, in meta-analysis summarizing the data, it is significantly superior to placebo for all of the above. And in people who are at metabolic risk, especially diabetics, it has been shown to improve glycemic control, core MACE, renal function, and actually there's early data that it reduces neurocognitive decline as well. You've seen this data with semaglutide. You get 59% resolution of NASH, but the effect with fibrosis is more modest. But if you look at the proportion of people who have progression of fibrosis, if you look at the placebo shown on the far right of your screen, you will see that it's about 18%. Then if you look at dose-wise, what we found is that there's a progressive dose-dependent decrease in the proportion of people who had progressive fibrosis. Remember that GLP-1s are working outside the liver. Then they have to reduce fatty acid and glucose delivery to the liver, reduce the fat in the liver, which in turn will reduce injury, which in turn will reduce inflammation, which in turn will reduce fibrosis. So the first thing when you slow this engine down is reduced progression before you get increased reversal. So it does work. Already the field has moved far beyond pure GLP-1. So from a weekly GLP-1, there are oral GLP-1s. Oral GLP-1, the original one with semaglutide, is about half as effective as the injectable one, but there are other second-generation oral GLP-1s that are looking really good. And beyond GLP-1, there is a combination with GIP, which allows you to dose higher, and combination with glucagon, which actually has direct liver targeting. And then there is a triple agonist with GLP-1, glucagon, GIP that I will actually present the data at the ADA later this year. And then, of course, there are oral small molecule agonists that have been developed. The GLP-GIP co-agonist, the GIP has additional effects both in the liver and in adipose tissue, which insulin sensitizes, and of course also allows higher dosing of GLP-1 because it ameliorates the nausea to some degree. And tirzepatide is the prototype compound for this, and this is the New England Journal paper. And as you can see over here, the degree of weight loss that you see over here is about 25% within 72 weeks. So we are really talking about bariatric level weight loss with tirzepatide, and in diabetes trials, dramatic improvement in liver enzymes, FIB4, and all the other markers of liver. And there's a phase 2 trial that is fully enrolled. We will report the results next year, this time with tirzepatide. GLP glucagon, similarly, glucagon oxidizes fat in the liver and actually improves mitophagy and generation of healthy mitochondria, thus reducing oxidative stress and inflammatory injury signaling from the glucagon, in addition to the extrahepatic benefits of GLP-1. And you saw, Anil showed this data with pemvidutide. There's also another molecule called cotadutide. Pemvidutide really is lead in class in terms of defatting the liver, and you can see pretty dramatic absolute and relative defatting of the liver. And there are already clinical trials with triple agonists for NASH that are ongoing. Hanmi is a Korean company which has a triple agonist. So to summarize, GLP-1s has emerged as a key anchor for the treatment of metabolic syndrome because of weight loss, improved MACE, improved renal outcomes, and glycemic complication. Second and third generation compounds are producing bariatric level weight loss and are likely to become the true comparators to bariatrics as medical therapy in the future. Nausea and GI tolerance are the main adverse events, and it really, you have to take, if you're going to use GLP-1s, you have to spend, just like with interferon, you have to learn how to use the molecule so that it is tolerable for the patients. Just telling them to take GLP-1s is not going to work because they're all going to come back vomiting and they'll stop taking the drug. So this is something that we can talk about in the discussion later. Thank you.